All right, good morning. We'll go ahead and get started. I'd love to introduce someone many of us know in our department, Dr. Accortt, who is a clinical psychologist specializing in perinatal mental health and the director of the Cedars-Sinai Reproductive Psychology Program. Her clinical research focuses on mood and anxiety disorders during the female reproductive life course and in response to chronic illness. She studies the physiological processes that are associated with higher risk for depression and anxiety in pregnancy, postpartum, perimenopause, and following diagnosis and treatment of heart disease in women. She is also interested in the association between maternal mental health and adverse pregnancy and birth outcomes, with a long-term goal of developing and testing effective interventions. Dr. Accortt earned her master's and doctoral degrees in 2004 and 2009, respectively, in clinical psychology at the University of Arizona. She completed her clinical internship at the Cincinnati Veteran Affairs Medical Center and was an assistant professor of psychology at Miami University in Ohio for a number of years. In 2014, she completed her postdoctoral fellowship in biobehavioral issues and physical and mental health at the University of California, Los Angeles, then joined the faculty at Cedars-Sinai Medical Center in 2015. Thanks again, Dr. Accortt, and I'll hand the screen over to you.
Thank you so much, Dr. Seat. I really am so happy to be here this morning to tell you all about all the work we've been doing to develop the reproductive psychology program. And what a lovely introduction. Thank you. So let's go ahead and just jump right in. These are the topics that I was hoping to cover today. I think it's important to start with the reasons behind this program, our why, and then talk about our five mission principles or core principles. I'm going to do a research review, tell you a little bit about what we've been up to, and then our clinical services, and update you all about that, as well as some of our future goals. So to really understand our why, I think we have to understand the challenge of the reproductive journey. So I'm curious if anyone here has heard of the term matrescence. And if so, if you care to participate today, you can send a reaction, a hands up. I'm just curious because I know I'm kind of flipping through the audience here, and probably a quarter of you or so have heard me speak before in the 10 years that I've been here. And I always like to talk about matrescence. I think it's really an important term, much like adolescence, right? So a developmental change that is biopsychosocial. It is becoming a mother. And essentially, like adolescence, which can be pretty smooth sailing for many people, it can also be very challenging for some people. And similarly, the experience of getting pregnant, staying pregnant, right? Possibly having perinatal losses, possibly having infertility struggles, potentially birth trauma due to pregnancy complications or other issues, as well as postpartum depression, anxiety, and other symptoms. The reproductive journey can be bumpy. And so I think this term matrescence, which really focuses on the true biopsychosocial changes that really all women go through, right? The hormonal shifts, the role shifts, going from maybe an independent, very independent person with very few dependents to one who now has this little baby completely dependent on you. Huge shift, and it can be very challenging. So for folks who have the most challenges, they're likely going to meet criteria for perinatal mood and anxiety disorders. And this really encompasses a range of mental health disorders. So this is not your mother's or grandmother's postpartum depression anymore, right? We're really talking about mood disorders, yes, but that can include bipolar or unipolar depression, a range of anxiety disorders, including panic disorder. It could include psychotic disorder, obsessive compulsive disorder, and certainly post-traumatic stress disorder. So if you take into account all of these conditions, and you realize that the past 20 or so years of research have shown that many of these conditions begin while one is trying to get pregnant and pregnant. We really need to consider the term perinatal. And that's what we do in the field now. We don't really just talk about postpartum. We talk about perinatal mood and anxiety disorders. And the prevalence rate is about 20%. So about 1 in 5 of your patients will be meeting criteria for one of these many disorders. Could be in pregnancy, could be postpartum. So PMADs for short, perinatal mood and anxiety disorders, are the most common complication of pregnancy, and left untreated can have truly devastating short and long-term consequences. And those consequences don't just affect the mother or the pregnant person, it also affects her spouse, her fetus or unborn child, then later infant, other children, society at large if she perhaps isn't able to return to work. And in a 2022 CDC report, they showed that mental health conditions account for up to 24% of perinatal deaths. And this was really striking when this came out, because for us in the field as clinical psychologists, reproductive psychiatrists, therapists of all kinds, it's pretty frustrating because effective interventions exist. We have psychotherapeutic, evidence-based psychotherapies, medications, and other interventions that work. However, less than 75% of our patients are getting treated. So, good spot to tell you about our 5 core principles. And I just have a timeline here, although this is when we were truly able to kind of effectively begin the process, right? We've always had these goals in mind, even back in 2015 when I joined as a research scientist. So I was licensed in Ohio, where we moved from, but I was not yet licensed in the state of California, and I was hired here to do research, and that's what I came to do. So that was the start of the program, was the clinical research, and I'll tell you a little bit about a few of our studies, recent studies. Then in 2017, we got together and realized that the wonderful depression screening that was going on hospital-wide, that the psychiatry department had started in 2014, I believe, wasn't really working well for our patients. So universal depression screening became one of our missions to really improve for our pregnant patients. Hospital community education, I guess today could be seen as an example of that, but I really do enjoy sharing all of this good information with colleagues across the university, across, excuse me, the medical center. And then we'll talk at the end of the presentation about our patient navigation services, as well as the treatments, interventions that we offer in the program. So let's go ahead and start with a bit of a research review. I think there's 8 or 9 IRB approved studies going on right now. And I obviously don't have time, so I'd love to tell you about all of them. But I'm just going to focus very briefly on the 5 that are going on right now that are in various stages of completion that I thought might be interesting to really share with you the breadth and depth of the research and the work that we do. So I'm going to start with telling you about our postpartum heart health registry and biorepository, then talk a bit about the postpartum depression quality improvement project, share with you some of the recent findings from the PROVIDE study, which is really our early biomarkers for PMADS work, as well as our RISE study for Black maternal mental health, and then wrapping up with our newest study, Family Foundations. So let's begin. Yes, in 2016, we created the Postpartum Heart Health Registry and Biorepository. And this follows women who had an adverse pregnancy outcome and collects a wide range of important physiological, biological, and psychosocial data over, our hope was, a long period of time, right? Because cardiovascular disease takes years to develop. So as you can see here, women agree to come in person every year for 5 years. So that first visit is within about 6 months of delivery. They're coming in about every year to have their blood drawn, physiological measurements taken, as well as medical record reviewed. And then they also agree to complete an online, annual online questionnaire. And our questionnaires, I think, are really important because we don't just ask about mental health symptoms, which is, of course, as a psychologist, what I'm really interested in, but we want to know, what do they think about their medical health and what's affecting it? Exercise, nutrition, other important variables like social support. And they've agreed to do this online forum every year for 5 years. And then our goal, if we were to get funding, external funding, would be to have them come back every 5 years. Well, not come back, but to fill out the online form every 5 years for up to 40 years. So to date, we have 125 women who are actively participating in this registry and biorepository, and we are no longer recruiting for this registry and biorepository. So these are some of the data that I mentioned. Really, our rationale is to collect the data for future research. And our underlying hypothesis is that women with adverse perinatal outcomes compared to term delivery, or I should say healthier deliveries, will demonstrate dysfunction in their physiology, for example, blood pressure indices, biological or biomarkers. For example, I'm very interested in inflammatory cytokines, and then, of course, their psychological symptoms. So data collection, this is a great time. We just finished V3. So what I'm showing you here is, I know a bit busy, but we have finished reaching out to everyone eligible for follow-up up to V3, which is around 2.5 years post-delivery. What you can see here is that even though we recruited over 250 women in 8+ years, people dropped out, they didn't respond. And so I'm still really proud that we have 125 women, many of whom are still returning. At V2, if you're looking at that total line near the bottom, 95 returned. Now, keeping in mind that, of course, we had a global pandemic. So not everyone, in fact, most patients were not interested for about 1.5 years to come in person. And so we see a big drop off in that V2 of in-person visits. And that's why we separated this into in-person versus online only, which of course affects our ability to collect biomarker data, right? Or vitals. So if we can't see them in person, we'll have limited data to analyze. But I think it's still really exciting to take a quick look at this data together with you. And this is the first time that we've presented these data to just really look at the physical health outcomes and the mental health outcomes. And I focused here on the 103 women with both V1 and V3 data. So that was our largest sample size. We are missing some data, as I mentioned, for some variables, depending on the patient. But I think just pointing out to you all that most of these women had gestational hypertension or preeclampsia, and that's the APO, or adverse perinatal outcome, that made them eligible for this particular registry. I added here the baby sent to NICU because you can see a very high percentage there. And we'll come back to that, the importance of psychosocial support for NICU moms as well as MFCU moms. And then, of course, postpartum readmission rates. As far as their mental health outcomes, I guess, we weren't surprised by that V1 time point. So 42%, and that's what you see in the literature of women who have pregnancy complications are twice as likely to have a perinatal mood and anxiety disorder. And so we weren't surprised necessarily by that V1. So PTSD symptoms are measured by the impact of events scale, or the IES, anxiety symptoms with the overall anxiety severity and impairment scale, or the OASIS, and depression symptoms with the Edinburgh postnatal depression scale. And there are cutoffs in the research for these measures. And so we just looked at how many of these patients were elevated, so above that risk cutoff, and found the part that surprised us was that at V3, which is 2 to 2.5 years post-delivery, a third of these patients were still struggling with their mental health. So that was interesting. There are not a lot of longitudinal studies like this looking at more persistent mental health concerns in the postpartum period. But I add here, whether they saw a mental health professional, because I think it's important to note everyone with elevated risk scores, not just at V1, at every single time point, actually, were provided with mental health resources. So it's heartening to see that at least, a very, relatively high percentage, nearly 40%, I guess, took us up or took someone up on the offer of mental health resources, and they were seeing these providers. So we do need to dig into these data more. This is, like I said, the very first time we've presented it. But sort of the take home for now is that of the 125 women recruited to the registry, we have complete physical and mental health data from 103 for visits 1 and 3. The majority of those women had preeclampsia or gestational hypertension. Approximately 40% had high risk for PTSD, anxiety, or depression within 6 months of delivery, but still approximately 30% continued to be at high risk 2.5 years post-delivery. So if we can get one of these grants that we have applied for, we would love to continue to assay these biomarkers that we have for many of these patients. And we are in the process already of analyzing blood pressure medication use, and just have a really wonderful supportive team in the cardiology department, women's heart health here at Cedars. So shout out to that group. So I'm going to switch gears and tell you a little bit now about our postpartum depression screening education and referral program. And this was a quality improvement study that we launched after, I guess it was around 2017. But the year before, we had organized a working group, and that included myself, OB-GYN and MFMs, psychiatrists, nurses, social workers from case management. We all came together to really change and improve how depression screening was facilitated on the inpatient unit. So the objective was to make some changes and then see, did these changes improve depression screening rates? Because when I came and took a look at the data in 2015, we were only screening about 10% of our patients, okay? Of those 10%, 0.0004 were screening positive. So it was really negligible. And we've had multiple interventions have taken place. So really what we're trying to ask is, has the screening rate improved? What of the interventions improves that rate? And then are the screen positive rates accurate? Meaning, are they in line with just postpartum prevalence rates? And that's closer to 10%. So that 20% really includes anxiety. It includes the prenatal period too. But what is happening with our patients, and is this new screening program working well? So the first QI intervention was in 2017 to 2019, and we moved the screening from labor and delivery and triage into the postpartum unit and did a lot of nurse education. And that increased our screening rates from 10 to 98%. But we found that when we looked at the data, right, we didn't just pat ourselves on the back. We took a stronger look, a harder look at the data, and we found the majority were still not screening positive. So we also learned that we have a lot of night nurses, we have a lot of travelers, and so the education we were doing in person was perhaps not really reaching everyone. So the training video that we created really improved that screen positive rate to almost 3%, which is great. And that's been published, so I'm happy to share that publication with you. The next two interventions were most recently when in 2022, we replaced the patient health questionnaire, which is a reliable and validated screening tool for depression, but we changed it to more of a gold standard for postpartum depression screening with the Edinburgh postnatal depression scale. And the other thing we did, which is I think very important, is we started using iPads, and that allows for privacy for patients to screen. So nurses in the past have been asking the 9 items aloud and putting in the answers into Epic. And so we realized that that was, although maybe building some rapport, wasn't really getting that accuracy that we were looking for and allowing patients to feel really comfortable to answer as openly and honestly as they might if they have privacy. So the nursing staff still introduces the concept of family wellness, explains the reason for screening, right? We're not trying to get anyone into trouble. We're trying to connect you to care, and then hands over the iPad for privacy. And we had over 20,000 births between these 2020 and 2023. And I can share with you that we still kept that really nice 98, 99% screening rate. But the odds of positive depression screenings post-initiative were 3 times the odds of pre-initiative. So even adjusting, for sociodemographic and health covariates. So we are seeing that the Edinburgh and using iPads is doing a better job. Really, we were doing a better job already. So regardless of the screening tool, 7.3 were positive for depression, but only 4% pre-initiative with the PHQ 9 and 11% or so post-initiative with the Edinburgh. What I think is really important, although both of these screening tools do ask about suicidal ideation, but I think it was that privacy that we afforded with handing the iPad over. We see an increase in individuals feeling comfortable to share that they are having thoughts of harm. So a total of 0.6% indicated SI, but that's 0.2% pre-initiative versus 1.1% post. Now, 1.1% may not seem like a lot, but with a data set this large, that's 84 women. So that's 84 women and that we may not have been able to immediately assist and help and connect to care. We would have just let them leave the hospital, and that's not okay. So I'm really, really heartened to see that we're able to use a better screening tool in a better way, and also pick up anxiety. So that's another benefit of the Edinburgh compared to the patient health questionnaire. It has anxiety items. Of course, just finding out if somebody is depressed or anxious is not the goal of this work. The goal is to connect patients to care. And if you screen positive above the cutoff of 10 on the Edinburgh, or if you have any suicidal ideation of any sort, you are going to be referred to social work. And you can see that our social work referrals increased. Now, this may seem like a very high social work referral rate in general. So this is not all due to our intervention. At Cedars, approximately 50% of our perinatal patients are offered social work referrals for all kinds of other reasons. It may be related to postpartum depression, anxiety, but domestic violence, substance abuse. If you are in the MFCU or NICU, you are automatically going to see social work. So one of the things we wrote about in this paper is, this may not be feasible in all healthcare settings to have this high of a rate of social work referrals, but we're really proud, and I'm really grateful to our inpatient social work team that they're able to really connect our patients to care. The other thing we're not able to see from these data is whether patients are actually following up, actually reaching out, actually getting that mental health care intervention, right? Following those social work referrals. But that's an important aspect of addressing perinatal mental health, and we will be exploring that in future research. Very quickly, some of the risk factors that we found out of this study. Asian, Black, and Hispanic patients were at higher odds of positive depression screening than white patients. Being single, having a personal history of depression or anxiety, or having a cesarean delivery increased the risk, not just for PPD, but also suicidal ideation. I already mentioned this, kind of a different statistical way of looking at the odds of suicidal ideation post-initiative were much higher. Asian patients in particular were statistically significantly at higher odds of indicating SI. And then finally, NICU admissions increased. And so it's really important to think about these NICU parents because they are also, like our MFCU moms, at higher risk. And that's well known in the literature. So if you'd like to read more about that, please do reach out to me via email. This is one of our most recent publications from the PPDQI. I'm happy to share it with you. Okay, so switching gears. So As the incidence of PMADs rises and the need for a serum diagnostic test becomes increasingly more important, this study was designed, our early biomarkers for PMAD study, to determine if there's a unique protein signature in the plasma of patients with PMAD risk. And we want to look at patients as early as possible. So I kind of think about this study and analogize it to the amazing work that was done decades ago with identifying gestational diabetes in our patients, and developing this test that we're able to all do when we're pregnant, which is a really gross drink that we drink, and then we are able to test in our blood whether we are at risk for gestational diabetes. This is kind of my goal, right, with this work eventually, to be able to have a test, whether there might be a panel of serum biomarkers. In particular, I mentioned I'm interested in inflammation, that might be able to predict who develops depression or anxiety within a year of postpartum. And inflammation could help diagnose PMADs. It's modifiable. So identification of its role may shed light on potential intervention targets, right? And provide really critical knowledge. So we have this pilot study of 52 women. They were recruited in the third trimester of their pregnancy. We gathered all kinds of data, in particular, took their blood and did mental health screening, followed them through their delivery and their postpartum visit, about 3 months postpartum, where we did mental health screening. So we really prospectively collected serum at both the prenatal. We did collect serum at the postpartum time point, but I'm not going to be reporting those findings. So preliminary PMAD data. So as you know, perinatal mood and anxiety disorders includes a range of depression and anxiety disorders during pregnancy and postpartum. So for this study, PMAD risk included women screening above validated cutoffs for depression with the Edinburgh. It's the same screening tools I always use. Anxiety with the OASIS, and PTSD risk with the IES. We had 52 women, 34 that met that criteria for high PMAD risk. So again, it could have been in the pregnancy, third trimester, or could have been up to 3 months postpartum when they met risk, or both. We also had 18 controls, and they were aptamer-based scanned to identify protein signatures with SomaScan. And this is a heat map of the top dysregulated proteins in those plasma samples. Among those subjects with PMADs, which you'll see on the right, so that red bar at the top on the right are our PMAD risk cases, and comparing them to the left, 18 controls. Upregulated proteins are shown in red, downregulated proteins in blue, and a protein expression was considered significantly dysregulated if the p-value was less than 0.01. So there are certainly outliers, but I just want to draw your attention to a unique protein signature that did differentiate PMAD cases from controls. These are some of those proteins here. And interestingly, they've all been implicated in neuronal survival and plasticity. And we saw those were lower in those with PMADs. What we did next, I think, is important. We removed those with adverse perinatal outcomes like preeclampsia. So we had a much smaller sample size. We restricted the analyses to exclude those cases. But interestingly, a different protein signature differentiated PMAD cases from controls. Increased expression of these proteins, and I just want to highlight beta-2 microglobulin because I'm going to share a little bit more about that with you in a moment. But these regulate leukocyte migration, inflammation, and immune function. So B2MG is a small protein normally found on the surface of many cells, including lymphocytes. You can find it in small amounts in the blood and urine. And our SomaScan results showed that there's the greatest separation between cases and controls with this protein as compared to those other proteins. And that's what you're looking at here on the right. B2MG values in other research have emerged as markers for activation of the cellular immune system. An increased amount in the blood or urine has been a sign of certain diseases. And in animal models, B2MG induced depressive and anxiety-like behaviors in rats in preclinical models of depression. So we were feeling very positive and optimistic about this, but of course we needed to then validate our SomaScan results using quantitative ELISA. We did that for the top 3 proteins. We found that indeed ELISA did confirm the SomaScan data, particularly for B2MG, which you can see is higher in our high-risk cases. So to conclude, the study highlights that there is a unique protein signature in a small pilot sample of pregnant and newly postpartum patients with PMADs. And this work really highlights that dysregulated proteins may actually differentiate PMAD cases from controls. Those PMAD-associated proteins converged around neuronal signaling and inflammation. And we need to do additional validation studies with larger samples. Future work is needed, of course. And these results provided the needed background for an NIH application that we submitted in the fall of last year. Bit of a delay here this year, but we hope to hear about that so that we can go ahead and continue this work in larger samples. And this is the paper, and again, I'm happy to send you all the papers. Anyone who's interested can email me. Really want to thank our research team as well as our funding sources, the Center for Research in Women's Health and Sex Differences, the Susan Hickman Memorial Research Award from PSI, as well as the Helping Hand, all provided some funding for this pilot study. So thank you to them. Okay, so this now is the time that I switch gears to 2 of our newer studies, unpublished work that I want to share with you all in various stages. So the Resources, Inspiration, Support, and Empowerment, otherwise known as the RISE study for Black maternal mental health, is an NIMHD funded study. Really proud, honored to be working with this wonderful group of physicians, scientists, and our community partners, Lauren Elliott, who's CEO of Candlelit Care, and Kelly O'Connor, Executive Director of Maternal Mental Health Now. And we worked together from the very beginning to sort of create this study. Our goal sample size is 150 Black pregnant women. And a little bit of background, I think, is important so you understand, again, the why behind the study. In California, Black women experience PMADs at nearly double the rate of white women. And despite the higher prevalence of PMADs in Black women, white women are still twice as likely to initiate mental health treatment. When Black women do initiate care, research has shown they're less likely to have any follow-up treatment and more likely to decline offers of medication and therapy. Additional barriers for Black patients is that they report in the research experiencing worse communication with their physicians, in particular those who don't look like them. They advocate less for themselves than their white counterparts and express discomfort when discussing mental health struggles with their white providers. And they report that the interventions that are being offered are culturally insensitive. They also noted that establishing relationships with community organizations really enhance their ability to manage their PMADs. So what we were all thinking about was how mobile health apps during the perinatal period can seem to bridge this divide. They improve symptoms, increase patient knowledge and self-efficacy. But what we learned was, that the majority of these perinatal mobile health apps cater to white women, and that further contributes to the health disparities that we're seeing. So our objective is to study and to test, really, mobile health web content informed by real-world experiences. These were focus groups of Black pregnant women that Lauren Elliott had convened years ago, and they had created these educational modules. And so participants in the RISE study are randomized to either the control group modules, which focus only on general psychoeducation and stress management techniques. This is pretty much like the other mobile health apps out there for PMADs. It helps them create a self-care plan that's uniquely developed by Maternal Mental Health Now to achieve emotional well-being during a very vulnerable time of life. But the intervention group modules focuses on all of the above, plus those culturally relevant modules that Lauren Elliott and her team in Candlelit Care created. And those were meant to increase self-advocacy and improve communication. So what does this randomized controlled trial include? We ask our Black pregnant patients to engage with the content for a minimum of an hour. It could be any time in their pregnancy. They are asked to complete online questionnaires. One is in pregnancy, two are postpartum. And these do ask about mental health symptoms, but it's also asking about experiences of medical discrimination, asking about their feelings of self-advocacy, how well they feel they communicate with their medical providers, social support. We also ask about exercise and nutrition and other factors that may be involved. If they do screen high on any of those mental health screening tools, they are invited to a structured diagnostic interview. It is a possibility. So not everybody gets that. And then an optional part of the study is biomarker collection. So you can opt in or opt out of that. And again, we know that studies have suggested that stress increases inflammation. So we wanted to explore this by collecting a small amount of blood at pregnancy and 3 months postpartum with the device you see on the right, known as a Tasso kit. So this has not been shared yet outside of our RISE study meeting. So happy to give an enrollment update since we launched in June 2023. And we're happy to receive an extension so we can continue working on this. We had 514 patients approached in person. This was about half from the Prenatal Diagnostic Center or other Cedars-Sinai OB clinics. So thank you to the staff and physicians and nurses in those clinics, especially the PDC, for allowing us to be with you and recruit your patients. We also got about half of those patients through social media. And so a shout out to our marketing team, social media folks, Dave Trier, Delara Skup, and others. Really appreciate their help because that was a major way that we approached women in the Los Angeles area. Approximately 200 or so were appropriate, eligible, and consented to the study. And some of these participants have withdrawn from the study for various reasons. Some have been lost to follow-up as they've gone through the steps, right? Delivery, postpartum. And so currently today, unless Pearl recruited someone this week, which she might have, we have 146 active or complete participants. And as I mentioned, our goal is 150. So we plan to be wrapping up recruitment this month. Very exciting. What are our next steps? We obviously do need to complete data collection. So even if we stop recruitment this month, we're still waiting on our participants to have their babies. And then we need to follow them into 3 months postpartum. We do have funding through May 2026 to complete data collection. We're really grateful that approximately 30% of our participants agreed to the optional blood collection. And so you can see here, we're still working on getting the rest of our samples in. 18 or so patients have completed both time points. So we have a goal of 30. That's what we have funding to assay. So we're hoping to get 30 of those in total. And then of course, data cleaning, assaying biomarkers, analysis will all come. Okay, finally, and I'm saying, yeah, I want to make sure to wrap up research so I can tell you about our clinical services. But this is our youngest study, the Family Foundation study, funded by the Winnick Family Foundation and launched just in April 2025. So the purpose of this study is to help women pregnant via ART to build a co-parenting bond and improve communication with a support person, a co-caregiver. So we are hoping to investigate whether this intervention will lead to reduction in depression, anxiety, and stress and improve medical outcomes. And we're going to examine the physiological mechanisms involved. Our study goal, it's a pilot study of 20 dyads, which are couples. Brief background, rates of anxiety and depression are high among individuals pregnant via ART, so 32% compared to that 20% that I told you about in the general population. ART treatment can be lengthy and expensive and commonly causes stress. And in the literature, we know that pregnant individuals via ART have higher stress biomarker levels compared to those pregnant via other methods. What is Family Foundations? So Mark Feinberg at Penn State developed this after decades of research with couples and new families. And it is a 9-session workshop, if you will, that really teaches attitudes and skills to foster positive parenting teamwork. And this is because the parent relationship and potential conflicts, especially the quality of parenting teamwork, strongly predicts children's and parents' future well-being. So what this program is covering is co-parenting techniques, but also individual emotion regulation, understanding temperament and secure attachment between parent and newborn, and positive parenting routines. Um, I'd like to give a shout out to Mark Feinberg for this, because this is a truly rigorous and incredible intervention. And he's done a lot of research on this intervention. 15 years of NIH-funded studies across 4 completed RCTs have shown the enduring benefits for parents and children. So you can see the decreases in PTB and birth weight or low birth weight, so higher birth weight babies, reduced hospital stay, reduced stress, anxiety, depression, reduced conflict and violence, and improved mental health in children. And then increasing supportive parenting teamwork, parenting sensitivity and warmth, infant regulation, later child social competence and school adjustment. And some of you may have heard of Gottman's. They're the psychologists who've done also a lot of research, and they developed an intervention that's very similar to this, to Family Foundations, called Gottman's Bringing Home Baby. So if you've heard of that, maybe you've even as a new parent done that intervention, it's very well marketed, but they don't have the kind of research support that Family Foundations has. So I always like to give a plug. So what we're doing here is women pregnant via ART are invited with their husband, partner, close friend, parent. It does not have to be a married partner, but just someone who can attend the majority of those virtual sessions with them, someone who's going to be around, right? A lot. They do have to be 12 to 30 weeks pregnant. They have to be 18 years of older. They can be anywhere in the US because we are offering Family Foundations virtually. Okay, so not to be too speedy here, but getting to our clinical services. If you have a patient who might be eligible or interested, they would be randomized to either the intervention group, and they would receive the Family Foundation's intervention as intended. So 5 sessions during the pregnancy and 4 postpartum, as opposed to being randomized to the control, which is just a delayed intervention. You attend all 9 sessions postpartum. Again, surveys, this time instead of TASO, we're doing at-home blood spot collection, which we hope will be easier, more feasible. And of course, attending all 9 virtual sessions is included. And we do have funding, as I mentioned, thanks to the Winnick Family Foundation. So we will be offering a grand total of $80 for full participation. But really the benefit is that they're receiving this Family Foundation's intervention for free. And so that's exciting. So I am so happy to share this flyer with you all. Please do scan this QR code. You can share that link directly with your patients. And we can laminate these. We have these laminated to bring to your clinic to put on the wall. We have a lot of REI docs who are already doing that, and we so appreciate their support in the community. So excited about getting going with that study soon. We do have 2 dyads already recruited. Okay, so let me tell you about the RPP clinically. Referring to the reproductive psychology program on the clinic side is similar to referring to ACM social work, except our social work team has a very nuanced understanding of perinatal mental health in the way that generalist social workers don't. So really what's happening is you will give this RAC card, which we're happy to share with you for your clinic, and patients will call us or email us, and the social workers will do an assessment. They will better understand the patient's needs, the type and severity of their symptoms, and most importantly, their insurance coverage, right? we may not be able to see the majority of patients because we're not in network. And so this is a really important piece. So please don't promise your patients, oh yeah, you can see Dr. Accortt. Oh yeah, you can see someone in her clinic. So the first step is this assessment. With the majority of our patients, either because we don't take their insurance or because at the moment we're not able to take a new patient, there is linkage with services outside of Cedars. I think this is critically important because it is always, I'm speaking for myself, overwhelming to navigate the healthcare system and insurance and what's covered and what's not covered. And mental health is even harder. There's carve outs, there's all these details, and our patients are sleep deprived, depressed, anxious, overwhelmed. They need someone to help them get linked, right, to the system. What that help may look like is different for each individual. It could be individual psychotherapy. It could be reproductive psychiatry. It could be a higher level of care, like an intensive outpatient program. And we have a couple good ones in the community. Or they need a doula, or they need a lactation consultant, or a parent class, right? So this support is really critical. What about what we do in the reproductive psychology program? Well, we do a lot for your patients. I always say we're still quite a skeleton crew. I mean, the reality is only one of us is a full-time clinician. So keeping that in mind, we really do support our patients primarily through our groups and classes. I'm going to put in the chat in just like 4 minutes when I'm done speaking, the link directly to this Eventbrite where all of our groups and classes are listed. We can send that link to patients. They can register and sign up directly through the website. So we really do want patients to be aware of those groups. Then we also offer individual psychotherapy. Okay, so as I mentioned, this is what it looks like when you click on that Eventbrite link. These are our current support groups and classes. They're all virtual. I want to start on the far left here by sharing our 4-session therapy group called Pathways to Perinatal Peace. This isn't a support group. This is a structured cognitive behavioral therapy group, right? We have been leading this since 2020. It's a great standalone intervention for those with mild to moderate symptoms of depression or anxiety. It can be any time of pregnancy, any time postpartum. It's a great option too for more severe cases. They may be on a waiting list for individual therapy in the community or with us. They may be waiting to get into that intensive outpatient. They need something now. And we can always get someone into that therapy group. Next, mentioning our amazing support groups for various conditions. You can see our infertility support group for couples. We have our endometriosis support group, ending a wanted pregnancy support group. And then you'll also see here that Family Foundations workshop, which is available to the community. You do not have to participate in research. So maybe someone here is pregnant, about to be a new parent, and you want to learn about how to prepare your partnership, right? Your family to be for this exciting but stressful change. You can register for our January workshop. The thing that I really just want to highlight is our free Preparing for Postpartum Wellness class. This is available in English or Spanish. It's not a support group. It is a one-time educational class. It's kind of like, I think about it as childbirth ed, right? It's for everybody. You don't have to be depressed or anxious to join. It's preparing for your wellness in the postpartum, thinking about sleep. It's absolute must. Thinking about how your partner can be involved. Partners are invited. So we really hope that you're sharing this with all of your patients. It is, as I said, free. It's every Tuesday at 11 a.m. in English. And we do have a Spanish option. We have had well, I won't say many. We've had several registrations since we started the once monthly Spanish option, but we've only ever had one person join in all the months that we've offered it. So if you have Spanish speaking patients, we really hope that you'll share this with them because we think it's a wonderful opportunity. Happy to provide these flyers. We can laminate them. We can drop them off in your clinic. It shares on the far right, the Preparing for Postpartum Wellness, that free class. On the left, these are our nursing offers a bunch of childbirth ed classes, but of course this link goes to those and ours, which are wonderful groups and classes I just reviewed with you. And then new and Epic, the referral to our reproductive psychology program. So you guys can email us, you can call, you can have your patients email or call. You can also put in a direct referral in Epic. Very briefly, I wanted to share our growth and our plans for the future with you guys. So as you know, we have about 6,500 deliveries each year here at Cedars. And many of those result in follow-up calls and direct referrals to our program. We really want to thank you for your referrals over all these years. And look how much we've grown. So 680 calls and orders in fiscal year 2023 to now over 1,100 calls and orders in 2025. In case you didn't know, we do have clinical training opportunities. If you are a student, a trainee in a PhD or PsyD program, you can come and do our practicum. It's 16 hours a week, and we focus on, of course, didactics, but supervised individual therapy. They carry 6 or 7 cases. They also do group therapy. They lead group therapy. We have supervision, and they often are involved in clinical research. Our social workers also launched a social work internship. So those are folks in an MSW program. They come for 20 hours a week. Similarly, didactics, they learn all those amazing patient navigation skills. They usually carry maybe 1 or 2 individual therapy clients. And of course, we all do really excellent supervision with them. We also have research training opportunities in the RPP. It's available at all levels. For the first 4, it is required that you're in a degree granting program to participate. We require a 1-year commitment and a minimum of 12 hours a week. And when one is able to commit more time and is interested, it always results in a conference poster presentation. It may be local, it may be national, and potentially an oral presentation or a published paper. So I've really enjoyed, I would go to say that this is the favorite part of my job, is the research and clinical training that I do. And so if you know anyone who might be interested, it's kind of exciting to see all of the great work that's come out over all these years with trainees. So here was one of our first publications with a trainee, a resident and a fellow working with us on a poster presentation, a postdoc who was working with us, and this paper came out. Again, undergrad researchers working on posters and even papers. This medical student worked with us on this paper. So really proud of all their work. And then finally, what's happening in 2026, exciting stuff. We are hoping to launch a reproductive psychiatry rotation. This will be with our longtime reproductive psychiatrist consultant, Dr. Simi Bambouche. We hope it will be starting in January, February at the latest. It will be once a month to start. And we hope that that will grow. Research-wise, we already have abstracts submitted for presentation at conferences, more to come. Papers are already submitted as well, and more will be. And then our clinical goals. We think it's truly important to get an inpatient psychologist on the staff. This is someone who would focus on our sickest patients, the ones who are at highest risk for PMADs. So this may be a dream. I hope it's a goal. I hope it's achievable so that they can work directly with our MF patients, our NICU parents, our PICU parents. So if you're interested in talking about that more, I'm happy to kind of brainstorm ways to make that happen. I'm also working with departments of psychiatry and neuropsychology to create an internship. So that would be a full-time experience for folks who are graduating PhD and PsyD students. And then for our research goals, always, always, always to get that funding, we have 3 grant applications pending. A goal of mine is to have a full-time postdoctoral fellow scientist join the team. We've never had a postdoc fellow as a scientist join. And of course, you know, some of our short-term goals. So what do you need from us? How can we support your practice? This is the team here on the left, clinical team, many trainees here part-time. On the right, our research team, again, several trainees. And in the center, me, Dr. Bambaget, reproductive psychiatrist, and then our postdoctoral fellow, a clinical fellow, our full-time clinician, who many of your referrals are probably going to. So thank you so much. Let me put the link in the chat and open it up for questions.
Thank you so much, Dr. Accortt. If you have any questions, please type them in the chat or go ahead and raise your hand and unmute yourself. I have a question. I mean, what a comprehensive review of all the work that you've done is quite impressive. Regarding kind of your interests in biomarkers and how I'm thinking about like the biomarker allopregnanolone, which at different parts of your pregnancy and postpartum, the levels are different, and with that big drop after delivery, then your risk for a PMAD increases significantly. When you're in your studies looking at different biomarkers, are you checking them at different points in time, or how do you choose at what point in the pregnancy to check certain biomarkers and how they would correlate with PMAD?
That's a really great question. We are working to expand the research that I shared with you. So thus far, we've only looked at that third trimester value, but we would love to do that sort of longitudinal multiple time points to look at first, second, third trimester, as well as multiple time points postpartum, and also ask about lactation, because the hormonal changes, of course, are going to change again if someone's lactating or completes lactation. But it's super interesting, the point you raise about allopregnanolone. It, in fact, is the basis of the only FDA-approved medication for postpartum depression. There's an infusion, there is now a pill, and Biogen is the pharmaceutical company. I'm actually going there in January to present some of our data, and I've applied for funding through them as well. So yes, it's exciting new work that's happening. Several scientists, several programs across the country. And if you're interested in this, I think the most robust research happening on this particular topic is probably out of UNC, Chapel Hill. And they have the most robust perinatal mood and anxiety disorders or reproductive psychiatry clinic. It's much like ours, but they actually have an inpatient mother-baby unit, and it's the only one in the country that I know of. So yeah, lots of amazing opportunities and ways to help our patients. We're just scratching the surface here. Great question.
Just a comment, amazing work, Dr. Accortt. Thank you for supporting all both through your research and clinical work.
Thank you so much. And I put my email address. I have a professional Instagram page where I always share new research and new clinical services. So would be super happy to keep in touch with you all. Shoot me an email and I will share one of those or any of those publications with you. And thank you all so much for being here. I really appreciate it.
All right, well, thank you, everyone. If there aren't any other questions.
Yeah, I'm happy to stick around.
I know we can all email you. You're very accessible.
Definitely.
All right. Well, have a good rest of the day.
Thank you, everyone. Take care.
Okay, take care.